thankful member of NPC-QIC. I've been able to be a part of CNOC and also the Cardiac Newborn Neurodevelopmental Network.
Hi everybody, my name's Michelle and I'm mom to Zach. He's now 2.5-year-old. He has HLHS. He had an NG tube until he was 7 months of age when we worked with a private company to do a hunger-based tube wean, which was very successful. On that last slide, he was the picture on the far left, and it's so fun to look at him. He's 6 months there and pretty much exactly 1 month before we got rid of that tube. But I'm also a clinical psychologist by profession, and I used to do behavioral feeding therapy for 8 years. So when I entered this world, it was from multiple perspectives. And my involvement with NPC-QIC has pretty much been founded on the quote of, "You were put on this mountain to show others it can be moved." So I hope the information that we share today, along with what Kiona and Michelle share, will be inspiring for patient care. All right, next slide.
Well, we, through NPC-QIC, the feeding work group, we wanted to do a deep literature search to find out more about tube weaning. We had discovered that studies showed us that somewhere between about 1/3 and half of our patients with complex heart disease really required some type of feeding tube early in life, but we knew the problems of tube dependency could occur. This is when children with stable health statuses and safe swallow function remain dependent on their feeding tubes to meet their nutritional needs. Tube dependency is often characterized by overt disinterest, avoidance, and active refusal of eating. They have often gagging and vomiting and other oppositional or aversive behaviors. Next slide. Through collaboration amongst parents and clinicians, we found that parents reported having lack of support to help their children wean off of their feeding tubes, and clinicians struggle with lack of evidence-based practice recommendations to help them. Next slide.
I'm honored to be here with Nancy to share the work our wonderful group has done. It started with a much larger group, but then whittled down to the names that you see here. We'd love to go into every detail of our review, but just don't have as much time, and we want Lori's to get a chance to speak. So next slide, please. So we ended up finding over 70 articles related to tube feeding, included several different types of studies. And as we looked through these articles, these kind of key ingredients started to emerge in the literature, and we'll present those to you today. One thing that we were paying close attention to how many children with CHD were included in these studies because they were more of a general medical focus, but it just over and over again, it ended up being about 20% of any study that included kids with CHD. There were a few that were focused on CHD, but at least 20%. So we feel pretty confident saying that this information is applicable to kids with congenital heart defects. And there's several different types of studies that you can see in this last point. Typically the programs would be about 2 to 4 weeks in length, but the success of tube weaning was not associated more with one type of program over another. Next slide.
So as Michelle just mentioned, when we reviewed the articles, we really found key ingredients or themes throughout the published data. A kind of recipe for successful tube weaning. Next slide. So the most commonly mentioned component of tube weaning programs that was mentioned in the literature was making sure that teams had a multidisciplinary approach. A comprehensive team offers the insight and clinical guidance necessary to address the behavioral, developmental, nutritional, oral motor, and sensory concerns related to severe feeding disorders. Next slide.
So hunger provocation ended up being the second most cited ingredient, not necessarily the most widely accepted, but it's important because tube weaning or tube dependency results from the child no longer connecting feelings of hunger to satiation through eating, especially oral eating. So hunger will end up, can be induced multiple ways. The feeding schedule might be manipulated. And then reduction of volume of what is fed through the tube is done to induce hunger. An example might be reducing 25% daily for the first several days. I'll throw some more data at you if you don't mind. It's important to note that nearly all the children in these studies began tube weaning programs taking less than 10% orally. It is common to see children accepting 0% orally before the tube weaning is started. And then what's amazing is that you will commonly see in the studies that within about a week or often less, the children will start engaging in oral eating. The success rate of these programs tend to be 80 to 90% of the participants, and those numbers often go up in the follow-up period after the formal program is done. And a note on weight loss. This is the most commonly cited reason why clinicians don't want to do hunger induction. You will see across studies 10% weight loss is the standard accepted amount of weight loss, and you'll see some studies that will go up to 15%. But what is amazing is the data consistently shows that weight loss rarely goes above 10%. Our studies showed 0.2 to 9.2% as an example range. Next slide, please.
So while making sure that you've got a good multidisciplinary team and that your team then thinks about hunger induction, the other commonly cited ingredients that we came across were those listed here. Positive mealtime and oral experiences means making sure that the child can associate positive things with successful eating. And this is really shown to contribute to successful tube weaning. While the child is still dependent on their feeding tube, they should be involved in normal mealtime environments with their families, exposure to all of the sensory components of feeding, seeing the food, smelling the food. Older children can participate in helping make the food, sitting down with their families, having food in front of them that they can touch and feel and maybe taste if they are interested. Any safe oral feeding should be supported, but never ever forced. The development and maintenance of positive mealtime experiences and oral skills is encouraged largely through continuing oral feeding experiences whenever possible.
With behavioral interventions, it's based on the idea that feeding refusal is a learned set of behaviors. Techniques commonly used would include positive and negative reinforcement as well as escape extinction. Force feeding, although commonly thought of in the behavioral feeding world, is not the approach that would be recommended.
Early tube weaning goals are also incredibly important. Despite our awareness of the problems of oral aversion and tube dependency, there is often a lack of education given to families about a plan for tube weaning when the feeding tubes are initially placed. A recommendation to improve caregiver education is that a specific plan should be documented in the child's medical chart with copies distributed to all involved health professionals and the family. And we really believe strongly, and data supports, that a plan for tube weaning should be discussed and officially planned at the time of tube placement.
And the caregiver education involvement piggybacks off of that, just including the caregivers at all steps, really thinking about supporting them with the stressors that they experience. That's been discussed a good bit today. Supporting the caregivers with education and support around the tube use and any complications that may arise.
And then the final ingredient that was talked about is making sure that there's a plan for follow-up intervention. While children can achieve significant success with really brief tube weaning programs, longer-term follow-up is a best practice and was incorporated across many of the studies that we've reviewed. Follow-up timelines and procedures should be individualized for each patient's needs. And the stuff that was in the literature really varied a lot. All
right, now we're excited to turn it over to Dr. Kiona Allen and Michelle Stelzer from Lurie's. Their presentation is exciting for several reasons. One is they saw a need for tube weaning and went with it despite fears and concerns. Two, they're having amazing success with kids from a wide range of backgrounds. And three, their process and data just happens to match on beautifully with what we found in the literature, even though we were working independently of one another. Next. Oh.
Thank you, Michelle. So we wanted to talk to you a little bit about what we've done here at Lurie Children's, which there are many centers who are trialing this all across the country. And it really is kind of coincidence that what we did lines up with what they found in their literature review, which was really just trial and error, to be honest, but I think reinforces that these strategies work. Next slide. Michelle and I have no relevant disclosures, but wanted to thank our partners in our multidisciplinary team, the single ventricle program, our speech pathology team, and also our nutrition partners. Next slide. So we were going to lay out for you the framework in which our tube weaning program takes place. Michelle and I both coordinate the interstage single ventricle program here at Lurie, and that's a nice population to do this in because we are so hands-on with them. And obviously feeding and nutrition has been a huge focus of NPC-QIC for a long time, and that's sort of where this was built from. So we created a structured tube weaning program, and we're going to show you a little bit about our preliminary outcomes, which we're also going to present as one of the abstracts in the top abstract competition at CNU at the end of next week. So I can't scoop all of that data or I'll get in trouble, but yes. So our interstage program here at Lurie basically follows children with single ventricle physiology throughout the interstage period and many times beyond that. We include children who are either going to go for Glenn or for a biventricular repair, but who have interstage physiology from birth to that next operation. We use a digital platform to help families track important vital signs, feeds, and weights, and then we use telemedicine to conduct weekly virtual visits, supplemented with monthly in-person visits. We're very fortunate that PT, OT, and speech are fully integrated into our team, both for virtual and in-person visits. And almost all of the feeding and nutrition support in our program is coordinated by us rather than GI or the pediatrician, as is common for many interstage programs. Next slide. So unfortunately, we don't have a consistent preoperative feeding protocol in the CICU at Lurie Children's, but we are fortunate to have speech, PT, OT, and nutrition support for all inpatient neonates starting on day 1 of life. Our program is one of those that does not place G-tubes during the interstage period, so children who need supplemental feeds go home with an NG tube that the parents are taught to use, including to replace if it comes out. Next slide. While we do a lot to support feeding during the interstage period, we found that our families feel somewhat abandoned once the intensive interstage monitoring phase ends. Many of our kids are still requiring supplemental NG feeds, and there are not, at the time of Glenn or 5-year repair, and there are not a lot of resources to help families navigate tube weaning. We found that our families often have to either kind of go rogue and figure this out on their own, or some of them are partnering with some of the expensive, excellent, but expensive private programs that will help families to do this. Our team was absolutely not comfortable managing this up front. And in fact, we were somewhat uncomfortable with the families who were going to the private program when this first started. We were worried about aspiration, worsening heart failure, were there going to be electrolyte abnormalities that would worsen arrhythmias? Were they going to be dehydrated? Was the surgeon going to yell at me? But we felt we owed it to our families to help them cross this bridge, and that because of the unique relationship that we have with them and how hands-on we've been with them leading up to this moment, that we were uniquely equipped to do so. So we implemented a structured, next slide, sorry. We implemented a structured tube weaning program in August of 2018, coordinated by our multidisciplinary team, which fortunately had been working with the family throughout the interstage period. And basically, because we were a little bit worried about doing it during the interstage period when children are so fragile, we moved to a system where all interstage graduates still requiring NG or G-tube feeds at the time of their bidirectional Glenn or biventricular repair were automatically sort of enrolled. Basically, there had to be a reason not to attempt a tube wean with them. Next slide. So kids were considered ready for a tube wean approximately 6 weeks after their Glenn or Bivy repair in order to ensure good wound healing and sort of a stable post-op trajectory of post-op recovery. And also at about 6 weeks post-op, the surgeon stopped paying attention to what you're doing. And that helps us to be better able to do things like allow children to lose weight. We wanted to make sure that they were demonstrating a good weight trajectory and a reasonable nutritional status, because in addition to not freaking out the surgeon, it's important to not freak out the pediatrician. We work with speech to ensure that we have strategies to improve positive feeding associations, and we really start that at birth, but we ramp it up after the Glenn or Bivy repair, and often because the kids kind of feel better and have less congestive heart failure, this is a great time to really work on that. We also partner with ENT and with our speech language pathology team to ensure that feeding can progress safely, particularly in kids with vocal cord abnormalities and swallowing dysfunction, to make sure we have a safe way to get in these younger kids liquids into them if there are aspiration concerns. And then we want them to have a stable cardiac status, which doesn't mean that you don't have any AV valve regurgitation or any ventricular dysfunction, but that you're well compensated on a reasonable regimen that we don't think is going to change too much. Next slide. Our protocol is customized to each child. So we get a lot of questions about like, what is your exact protocol? But I think like Michelle and Nancy talked about, it's really more like a recipe that you can tweak for each individual child. I mean, it really needs to take into account what their strengths and weaknesses are, which as the interstage team has really worked with them, we usually know. It typically occurs in 4 to 5 phases with a reduction of volume and or calories at each phase. And each phase typically lasts about a week in order to allow for the development of appetite or thirst, but not longer than that. And in the beginning, we had issues with that where kids would sort of be in a phase and they weren't really making what looked like progress, and we would be worried about moving to the next phase. But we found that if we stay on one phase for too long, they actually plateau, lose weight, but don't develop enough hunger or thirst to progress. So many times we have to kind of force ourselves to push them to the next phase, even if they don't seem like they've made progress yet. Since our families are already very comfortable with our interstage home monitoring platform, we just continue that until the wean is done, which really helps us to support families as they navigate the wean. And then this is supplemented with monthly in-person visits coordinated with PT, OT, and speech. And then we also collaborate with early intervention or other outpatient therapists to further support families. So we reviewed our data, next slide, sorry. We reviewed our data last year and presented it at CHOP conference this past February. Of the 21 patients in our interstage program, like in the time frame that we looked at, 7 were all PO fed shortly, either at the time of Glenn or Bivy repair or shortly thereafter. 2 patients declined, one to do a private tube weaning program, and one the family just felt like it would be too much. And then 2 patients were excluded because of concerns they couldn't safely orally feed. One had a tracheostomy and the other had major vocal cord issues, and we really couldn't find a safe way to feed her by mouth. So they both underwent G-tube placement. So we started out with 10 consecutive patients that we were able to do this with. Next slide. So this slide has a lot of information on it. It just sort of is a little case series of the 10 consecutive patients that we did. As you can see, it included children with prematurity, with low birth weight, as the smallest was 1.6 kilograms, complex congenital heart disease including HLHS, pulmonary arterial MAPCAs, prolonged newborn length of stays to as long as 6 months for our smallest patients, aspiration, vocal cord issues, important residual cardiac issues like important AV valve regurgitation or ventricular dysfunction. We had kids on amiodarone, we had kids on digoxin. All of that was very scary to us in the beginning. And just as importantly, at the time of the tube wean, many patients were taking a combination of PONG, but we absolutely had patients with severe oral aversion who were really unable to tolerate any feeds by mouth leading up to the start of the wean. We successfully, next slide. We successfully weaned all 10 patients in a median of 18 days. While we were able to get to all PO feeds in about 3 to 4 weeks, consistent weight gain definitely took longer. So it took us about 6 weeks to see a consistent weight gain trajectory. There was a prolonged period of weight plateau. No patient lost more than 10% of their body weight during the initial weaning phase, and most lost much less than that, like closer to 3%. At this time, actually this is not so true. 9 of the 10 patients were entirely PO fed at the time we presented it. 1 ended up readmitted and received a transplant and is now back to all PO fed. So 10 out of 10 are actually still all PO fed. I know that it feels like hard to imagine how this would work. So we thought it would help if we actually ran through a sample patient for you so you could see what that looks like and how we built this for her. Next slide.
So this is one of the 10 patients. This is patient number 9. Her name is Aria, and we have permission to share from the family. So she was, definitely, one of our higher risk patients, a small birth weight. She really, clinically was stable at home. But she was 2 hours away from the surgical center. She was on higher calories. Feeds were running over 90 minutes, and she really didn't take much by mouth. And we definitely had the swallow evaluation concerns as well. So she was definitely a high risk kid. Next slide. So just to walk you through her phase, again, we sort of championed our program after the early work of NPC-QIC about 6 weeks after. So once she was 6 weeks after the Glen, that was when we started the tube wean, and her phase started with a 20 or 39% tube wean, and we adjusted her feeds down accordingly, continued to work on her oral feeds, moved to phase 2 and phase 3 and phase 4 over time. And really, she did not take a lot by mouth initially when we started this wean. And it was very difficult to get her to actually start to drink from a cup, from a honey bear. Like, there was a lot of these other strategies and ingredients that needed to happen in order for us to sort of move through this. On her case, because of the prematurity, we kept her on, hold on.
Motion sensor light.
Motion sensor. We kept her on 27 calorie initially. That's not typically our MO. We usually start at 24 calorie, but in her instance, because of the prematurity and her size, we kept her until later in the wean. Next slide. And you can see this is with our Locus platform that we continued on during the post interstage period. And you can see the green is with the NG tube. And then when we transitioned out without the NG tube, you can see her volumes over time and the success, over many weeks and months. Next slide. And you can also see the growth curve. There was definitely a drop and then a plateau and a trend upward. And I think that's what we've seen in all of our kids, that there is some drop when we eliminate the NG tube and they start to get their act together over a few weeks. But what's important is that we haven't really seen significant and important weight loss that has required kids to actually come back. She did not have to come back, even though she was minimally taking volumes by mouth. Next slide. And so, again, another key ingredient is teaching how to eat. And here you can see Aria, she established a stable weight trajectory. She transitioned out of the interstage clinic, followed back to her local cardiologist in Rockford, that's 2 hours away from us. And, we coordinated some visits initially, to make sure that we felt comfortable, but now all of her care is locally with her referring cardiologist. We did continue some home monitoring and virtual visits initially, but that's all been discontinued. And, she really, touches touches us with, the importance of continuing that intensive care throughout the interstage period and continuing it after the Glen to help support families to get rid of that feeding tube and grow and thrive. Next slide. Next slide. Oh, sorry. In our initial report, we had the 10 patients, but now it's 22 patients and even more. And really, this just gives you a brief summary of, the graduates that we've had, over time. The median time to achieve all PO was less than 3 weeks. And you can see that there wasn't significant weight loss. There was no major adverse event. There was no readmissions for concerning feeding issues. Constipation was very high, and we have to address that. We learned early that we have to get on top of that early. And we actually weaned 2 patients in DCFS custody, and one was on amiodarone. We did in that particular patient do a 5-phase wean because we were a little scared about it. But our goal as NPC is to get everybody eating, their first birthday cake, all successful oral feeds. And we feel like this is in line with the message that parents want and what we as providers want. Next slide. And, here you can see Aria, her first Halloween. It's definitely different this year.
For the dietitians on this, we recognize that's not good nutrition. We're sorry.
But it's also fall, and it's also pretty darn cute. But there definitely are challenges, and some of the challenges were echoed in the early part of the presentation by the literature review. And it really requires an extended commitment by the interstage team. We could not do this without our developmental team. Absolutely. It is time intensive. It absolutely deploys a lot of resources to help support families get through this. And, definitely it requires psychosocial support, which we unfortunately as an institution do not have right now, a lot of psychosocial support for the interstage kids. And, uncertain future with telehealth billing right now in COVID, we certainly have the opportunities to do that. But before COVID, we could not bill for any of these visits. And then just difficulties with maintaining, efficient communication for all of our families. Because when families have a question, they need to get an answer. They don't need to be parked on hold. They need to get to their provider in a timely fashion. And so there's a lot of challenges to make it work. But I think, we've been very pleased and proud of what we've done so far.
Emily, there were a lot of questions in the chat. Do you want us to just start answering them?
Yeah, so we are actually at time right now.
Oh,
I'm sorry about that.
That's okay. That's okay. I just want to thank all of our presenters and our attendees today. But Michelle and Kiona, I think there were a couple questions for you. So you can either answer them now or I can send those to you through email, whichever you prefer.
I think we'd be happy to answer them now. Is it going to boot us out?
No, we can stay on.
If people are willing to stay on, we're happy to answer them now. I think we also are easily accessible by email if people want to email us. Sure. So let's see. I think there were a lot of questions about fluid status and dehydration. What we learned from shamelessly stealing from some of the private programs is that we are all kind of overreacting about that, to be honest. And what we do is monitor more closely than many of those private programs. You really, we don't, we're tracking ins, not outs, right? In that we're still tracking what they take PO. And many times what we found is that they're not taking maintenance, which really freaks us out, but they don't seem to care. They just don't, nothing bad happens to them. They don't lose tremendous weight. They don't have sunken eyes. They're still crying tears. Their mucous membranes are still moist. They do get constipated and we have to treat that, but that's really the only adverse event that we've seen from a dehydration standpoint. And we haven't really had to supplement with water. We've had to supplement with prune juice, but I don't think there's anybody that we've actually added free water because we want them to be thirsty and to take actual good nutrition. So we just kind of ride it out, to be totally honest, and that's been okay so far. But there have been like whole weeks at a time where we're looking at the recorded intake and we're like, but it seems like it's fine, and the parents are told what to watch for. And so we would bring them in if they seemed like they had clinical dehydration. They just have numerical dehydration, I guess.
Yeah. And the other thing to just shout out too is that, you know, again, like the literature review talked about all the ingredients, and, you know, some of the other speakers have talked about, you really have to make sure that engagement with the parents and they're ready for it, the parental readiness for it. Because there are some behavioral things that can happen, you know, when kids get a little bit dehydrated, and, you know, just working with the positive, you know, feeding skills, and it just, everybody on the team has to be ready for it, and the kid has to be in the best health possible. Like if there's an intercurrent illness that's maybe going on, a kid has a cold, you have to rethink that plan of when to start it.
I think it's a combination of two things. Like, you don't want to do it and sabotage yourself, because I think we're still building confidence with this. So we really try to start it when we think we're in a good place. But I think we initially were more worried about when kids were complex, or they had like a chronic problem that seemed like it would be challenging to manage. And if it's really stable, we actually haven't really seen that be an issue. Like somebody asked about if you have horrible oral aversion and you won't take a pacifier. We have had kids who you like put formula near them and they start gagging. And we've been able to wean those kids too. We've not yet had anyone fail for just oral aversion alone. Sometimes you have to be creative about what are they going to eat. Like, are we going straight to sort of thin purees, and we change around the formula because maybe they have an association with this horrible formula they're on. When we have kids who have chylous effusions, many times we'll wait until they don't need Alimentum or Elicare or Monogen or whatever. I mean Elicare, Monogen anymore. Or if we think they have milk protein allergy, we wait until they don't need Alimentum or Elicare anymore. But we've done it even with those things. We've had children who had enough aspiration that they needed. We had one who needed honey thick feeds, which was very unpleasant for everyone involved, but she was able to do it. And then someone asked about ARIA and the swallow piece. We were looking back and realizing that part of what happened with her is that she was taking so little that we couldn't do a formal swallow study because she wouldn't take more than 2 or 3 mLs at a time. And so then we decided to move ahead. Clinically, she looked safe. So we moved ahead with the wean, and she did the whole wean, like between inpatient visits. She did it in 3 weeks. So we started it telemedicine. She weaned all the way to all PO. And you saw in that slide, she like did nothing for 2 weeks and then suddenly was taking all PO. She did nothing. Like, it was pretty scary actually. And then was suddenly taking all PO. And by the time she came back to clinic, she was stably on all PO. And so then we did a swallow study and discovered that she was aspirating. And then we thickened her feeds. And fortunately, she liked purees better than thin liquids anyway. So we were able to keep her going with that. But it's not like there is no algorithm. There is, it just takes people to care about this, to trust the family, to partner together. Like, the number of phone calls that we get about like, is this okay? What do we do? It takes a lot of manpower, but it's not rocket science. It's just about deciding that you're going to take it on, I guess.
Yeah. And a lot of the variables are the age of the kid. If you're tackling this at 4 months, your tools and your, in your toolbox are a little bit different than somebody who's like 9 months or 12 months of age. And you are not even thinking that the bottle is going to be an option. So like, there's all these like practical things that, we were very hesitant to like share any kind of like a general guideline, because every kid is so unique. And your team, having that strong multidisciplinary team that can bounce things off of each other, talk about things in the moment, and come up with plans that, may or may not work, and then adjust accordingly, is really like the critical piece to having, a successful outcome, I think, at least.
We have had one kid, Allison just asked about bolus feeds. We had one kid who was on continuous overnight feeds and small volume bolus feeds during the day. And we actually built that one so that she was getting we cut the bolus volume way down first. And then she still got continuous overnight feeds just so that we didn't get so dehydrated so quickly, because she also did not do anything in the very beginning. So we have done it without tolerating bolus feeds. And I guess it depends also on what you mean by tolerating bolus feeds, because we've absolutely had kids who were on bolus feeds who threw up a great deal before the tube wean, who actually, for the most part, did not throw up after it.
Yeah.
So I think we've done we have done that for sure. Starting to. For Sarah, I do think that, as Michelle was saying, doing it with older kids is much harder. Like, it's much more straightforward when you're just trying to wean a kid who's on only formula. When you're trying to add in real foods, we mostly follow the same general concepts as general feeds. So sort of like, yes, one food at a time, but also, messy play and all the behavioral things where you're exposing kids to a lot of different things, because for our kids, many times they just don't like certain things. And you just have to play around with it to find what they like. But we really lean on speech therapy and our dietitians to help us with that. And we have been very fortunate that they will even jump on our telemedicine calls so that they can actually put a kid in a high chair in their own kitchen and watch them try to eat and help the family troubleshoot some of those things and help build positive feeding behavior. So we found that to be super, super useful. It's just not possible for every center to do.
Mm-hmm. Yeah, that's really important. And there's also some kids tend to be a little bit more sensitive than others. Speaking of that messy play and, trying to get them to put things in their mouth and things it's that coordinated developmental effort that is really critical. And for this particular patient that I shared, one of the really cool things that happened during her tube wean and interstage period was I actually had a telecall, and I was actually on the telecall with the patient and the parent, and they were in the kitchen in the high chair, and they also had all the developmental early intervention providers in the home, so they could ask questions about what we were about to embark on and how to support them, which is really kind of cool. If you try to find the positives in things, especially in this COVID environment.
We don't usually add high calorie during the wean. After, when we're in that plateau phase, a lot of times we end up having to really push high calorie foods to get them back onto a positive growth trajectory. But that we certainly rely on our dietitian to help guide us through that. We'll be presenting more about our data, like I said, at CNU. I can't remember what day that is. I think it's Thursday. But I know there's a lot of CNU people on this call, so some of you hopefully will join that conference and see it. And thank you so much. I think we're so excited that everyone's so excited about this.
Thank you so much, everyone. And we will be sending out an email with the CME instructions shortly after this breakout.